evening, everyone. My name is Bethany Yiser. I'm president of the CURESZ Foundation, and it's a great privilege to help facilitate this virtual lecture series. And this is primarily for CURESZ clubs, which are small student gatherings. Please contact us if you're a student and you're interested in developing your leadership skills and helping educate your peers and friends about severe mental illness. Our first speaker for our 2024-25 virtual lecture series is Dr. Robert Smith. He is professor and chair and research director of the Neurosciences Institute in the College of Medicine and Life Sciences at the University of Toledo. He's an expert on schizophrenia, depression, and autism spectrum disorders, among other disorders. And I will say he recently reversed cognitive deficits in an animal model of cognitive dysfunction with a repurposed FDA-approved drug. So just a little bit more about Dr. Smith. So, okay, Dr. Smith, take it away.
Hey, everybody. Thanks for being here tonight. And we're going to talk about a topic that I've been interested in lately. Sometimes it turns into a rant. And so when Bethany and I were talking about maybe the theme for tonight, the idea of diagnoses came up, and the title is the word nosology. That really refers to sort of the study of naming things or giving things a diagnosis. And so that's going to kind of be the theme tonight. And disclosure, none of the disclosures here have anything to do with tonight's talk. As Bethany introduced, so I'm up at the University of Toledo, and we do a lot of stuff up there, including training psychiatrists. And today I'm going to be helped out by Dr. Sirtaj Singh, and I'll introduce him a little bit more later. He's gonna do the talking in the middle part of the talk. And he's one of our very best residents at the University of Toledo with an interest in this topic. So, you know, most of you who are on this call know what schizophrenia is and know how it manifests. And, you know, we may even have consumers and persons who happen to have this diagnosis on the call. And, you know, it kind of breaks down into three broad symptom areas: the negative symptoms, the things that are missing; the positive symptoms that are often in the psychosis bucket; the things that are present that are not supposed to be. And really what people think of as in 2024 is very central to schizophrenia is the cognitive impairment, which can involve memory, executive function, and other cognitive modalities that are really disrupted in schizophrenia. So again, we're talking about nosology or diagnosis. And for many, many years, the field of psychiatry, the field of people treating and studying mental illness or mental disorders has relied on diagnostic criteria. And Sirtaj is going to go into the history of this, which is a very fascinating history. Just know that this started a long time ago, and he'll tell us about that. But what we've got in 2024 is a set of criteria that we can all agree on. And there's a really important reason for this. So if you're studying schizophrenia in Paris or Australia or Japan or South Africa or Los Angeles or Toronto, we all need to agree that we're studying the same thing. But when you look at this, you know, this is a very descriptive diagnosis: delusions, hallucinations, speech, negative symptoms. This is very descriptive and observational. There's nothing on here that's a blood test. There's nothing on here that's a biomarker, you know. So this gets into a really interesting area. So if you have chest pain and it's radiating down your left arm, and you go to the emergency room and they're worried you're having a heart attack, they draw your blood and they measure a couple of enzymes that are biomarkers of a heart attack. They put leads on your chest and do an EKG, and if you have ST segment changes, that suggests you have a heart attack. They also give you oxygen, have you chew an aspirin, may or may not give you a beta blocker, depending on the protocol, and they're off to the races. If you go into the emergency room and you say, I don't feel good, or I feel depressed, or I'm hearing voices, they're going to ask you how you feel about that. There's no blood test, there's no biomarker, there's no neurophysiology we can do to say, oh yeah, you're suicidal, or oh yeah, you have schizophrenia. So the diagnostic criteria are descriptive and observational. And as such, they aren't anchored in molecular biology. They are not anchored in genetics or really anything else. It's just, hey, if you've got this sort of agglutination of signs and symptoms, we're going to call it schizophrenia. And that kind of gets back to a couple of definitions. A syndrome is when you have a bunch of things that you all agree, if it all looks the same, we're going to call it that. Whereas a disease is something that you know the cause of. For example, diabetes, the islet cells in your pancreas die. You can no longer make insulin. Your blood glucose level goes up. You get diabetic ketoacidosis, and without an intervention, you may die. It may be debatable what the cause of the islet cells dying is. There are many causes that are known, some are unknown, but that's clearly a disease. Where, in contrast, schizophrenia, we don't really know specifically what causes schizophrenia. And so it's more of a syndromic construct. Semantically, we all kind of agree, hey, if you kind of have this stuff, we're going to give you this diagnosis. So another sort of side rant about the genetics of human illness. So I was a graduate student at the University of Michigan. Francis Collins was there. And Francis Collins was very famous. He's the person who helped clone the human genome. He was the initial director of the Institute for Genome Research and was most recently the director of NIH. And so they had done positional cloning, old school cloning, and identified the breast cancer gene. We're sitting there in a press conference in one of our big lecture halls. They're very excited and they're pounding the table. We just discovered the breast cancer gene. This is very hard. This is very hard to do. BRCA1 and BRCA2. And you can see on the chart that their mutations accounted for about 8 or 9% of all breast cancers. And I'm like, 8%? That's terrible. You're telling me I got out of bed and came up to this press conference to listen to someone tell me you only got 8% of breast cancer? The truth of the matter is, I was very naive and didn't know what I was talking about. If you gave me 8% causality of any disease, we'd give you a big prize now, especially schizophrenia, because we don't have anything that accounts for 8% of schizophrenia. So that leads to another tale about diagnoses. And this relates to schizophrenia more directly. This is a pedigree. And a pedigree, if you're not familiar, you've got a man and a woman. So that would be the pairs that are, kind of two people together. And then the next line down is their children. And then the line down from that is their grandchildren and so on and so forth. And this is a cohort, a pedigree of a family from Scotland. And they have a rare mutation, a very rare mutation. It's called the DISC mutation, DISC. And if you see an asterisk next to one of those squares, each square is a person. If you see an asterisk or a little star, black star, that means that person has the mutation based on genetic testing. And then we've got some diagnoses, descriptive diagnoses. If you have a solid filled in sort of diamond, you have schizophrenia. If you have a circle in the middle of your diamond, you have bipolar. If you have a half filled in diamond, you have depression. And so this is the most highly potent gene that can cause schizophrenia we have ever discovered. It's called the DISC gene. They named it DISC because it's disrupted in schizophrenia, DISC. All right. But if you look carefully at the numbers I've put on this slide, 11 of the patients who are the carriers for this schizophrenia mutation have a mood disorder and don't have schizophrenia. So it's the best smoking gun for a cause of schizophrenia is a gene they named disrupted in schizophrenia when actually it probably should have been named disrupted in severe mental illness. So this belies the problem of diagnoses. So the genetic risk, the same genetic risk, can give you a different clinical phenotype. Some people have this rare mutation and they have a phenotype of disease that looks like schizophrenia. Others have this mutation and they get depression. And it's a series of all the interactions of all the other genes, random coin flip events during development, environmental stress, other potential causal factors that can lead to the development of a patient having the appearance of depression or the appearance of schizophrenia. And so using genetics alone to try to say something about schizophrenia as a diagnosis and whether or not there's subtypes is fraught with peril and kind of reflects the DSM-5 criteria that we have They don't rely on any genetics or any biomarkers. So I'm going to toss this now to Dr. Singh, Sirtaj Singh. He is a physician. He is in the child and adolescent training track at the University of Toledo in the Department of Neurosciences and Psychiatry. He's a PGY3 resident, which means he did 12 years of grade school. He did 4 years of undergrad, 4 years of med school, and now has done 3 years of residency, or is at the beginning of his third year of residency. If you add all that up, that's 12, 16, 20. He's in the 23rd grade. And so he's going to talk to you a little bit about the need for psychiatric classifications. And Sirtaj, when you want the slide advanced, just say next slide.
Wonderful. Thank you for the introduction, Dr. Smith. I'm excited to be here. I just wanted to preface some of my slides by saying a lot of the language that was used back in the 1800s and 1900s was a bit different language we use now and a bit more degrading. So it's also interesting to see how the classification changes over time in terms of the demeanor in which we approach our language for mental illness. But starting off in the 1840s, that's kind of the first time when there was an attempt to find a way to categorize mental illness and to estimate how much mental illness there is in the US. And it was in the census test in 1840. And they had only one option, and that's idiocy or insanity. About 3 years later, there was a protest from the American Statistical Association outside the House of Representatives because they were saying that, you know, how useful is this in terms of, and the words they used were respecting nosology, prevalence of insanity among the people of this nation. And one of the reasons was because there were many towns that were primarily African American. Yeah, so they kind of found the use of idiocy and insanity useless. So soon after, the Association of Medical Superintendents of America, American Institutions for the Insane. This is the oldest medical specialty organization and was a group of neurologists and psychiatrists interested in mental health. It was formed in 1844. And so with the they kind of were starting to think about how do we diagnose these things, how do we define these things. And then in World War II, we ended up with a lot of veterans coming home with mental illness. And so there was a significant change in how we approached that later in the 1900s. But between those times, we had a bit of an increase. You know, we went from one diagnosis of idiocy insanity to in 1880, there was mania, melancholia, some more affective, some more mood-related disorders. And then we have paresis, we have dementia, epilepsy, and then there's the International Classification of Diseases. Now, this is what a lot of the world uses for a lot of different diseases. And in 1948, again, with the Veteran Association in the States, they had these 10 categories of mental illness. And then we had our first diagnostic and statistical manual of mental disorders in 1952. So I'll kind of go through the history a little bit more, but that's a good overarching timeline of 1840. We don't really have anything. We have one diagnosis for everybody. And then 1952, we have our first official diagnostic and statistical manual for mental disorders. Next slide, please. So we start with in 1809, kind of they're trying to describe these patients that they see, right? So John Haslam is describing this madness in young people. In 1810, Philippe Pinel is describing idiocy, and he says more or less an absolute obliteration of functions involved in understanding, which I think points towards the cognitive deficits that Dr. Smith was pointing towards. In 1865, they added more of those negative symptoms Dr. Smith is talking about, like fixed affective madness, and then agitated or apathetic dementia. And a lot of how they thought about this disease was they thought of it as a very progressive disease because, again, they had no treatments at the time. Next slide, please. So in 1889, that's when we start to get a semblance of a diagnosis for these patients. Kreplin called it dementia praecox. He called it that because, he noticed a mental disorder primarily affecting and starting in young people. I think that in the beginning, they thought it had to be in people who are less than 40 years old or 35 years old, around that age. And he kind of combined different things that other psychiatrists at the time had described. And he put it under one category, dementia praecox, and he put in some subcategories. So there's a subcategory, and I'll go into these more later, but one was catatonia, one was hebephrenia, and then the other was paranoid. Talk a little bit about them more later. And then he also described, again, these changes in emotions that these people were having. And they wanted to distinguish this from the dementia later in life that often they saw in patients with syphilis, for example, as well as the what we now see as bipolar disorder and depression, which is primarily mood-related disorders. So they created this dementia praecox. Next slide, please. Okay, so again, it's this, they describe this as this emotional dullness. That's really pointing towards the apathetic symptoms in some of these patients. So they will, for example, when we write our mental status examination on patients, we will say a patient with schizophrenia may present when they're not being treated with a flat affect, meaning they won't really respond with the same nonverbal excitement or sadness that other people would. It's also something you would see in actually like late stage Parkinson's, for example, is you won't get that facial response or that change in the voice doesn't respond as well. These nonverbal cues kind of change. And there's these deficits seem to get worse over time. So that's how they would distinguish it from like just a paranoid disorder where somebody is worried about something to a pretty significant degree, paranoia, but not to the point of them deteriorating over time in function, because again, we didn't have any treatments at the time. So there was 10 different forms at first, and then there was 9 different end states, because again, the end states, they were thinking a lot of a progressive disease for these patients. Next slide, please. And now we touch on the first time we used the word schizophrenia. This is 1911. So we went from 1840 idiocy, insanity, very broad, not useful at all. We had the late 1800s with dementia praecox, and now we have Bleuler's schizophrenia. So his first approach was pretty descriptive. So he used an approach that we now use with schizophrenia, which is a lot. Or we kind of use, which is that you have some primary symptoms and some secondary symptoms, and you have to have some of the fundamental symptoms, so some of the primary symptoms. And so in this description, we're thinking about changes in thoughts. So when Dr. Smith teaches about schizophrenia to residents, he describes it as a thought disorder. So you have changes in how people are thinking. That's also like a very key distinguishing factor for schizophrenia. And then the other side is the hallucinations and delusions. And that's how they're perceiving the world, how they're interacting with the world. He went on to kind of fine tune some of that a little bit more. And the primary diagnosis, again, the loosening of thought associations. So a good way to think about this is, again, in our mental status exam, what we're trying to see is, do this patient's thoughts clearly connect with each other? When they talk, can I follow their line of thought clearly, or are there some separations or jumping patterns that don't quite make sense, where you have to make assumptions that you don't really follow with the patient? And that can happen in the speech, it can happen in the thoughts, it can even happen in the behaviors. But that's one thing we always look out for if we're thinking schizophrenia, and especially in an acute episode specifically. And again, the catatonic symptoms, they were trying to figure out who is a quote unquote severe patient, who is not. Catatonia was seen as a severe presentation of this, of schizophrenia. All right, next slide, please. So again, as a thought disorder. So back in the day in training, they really were, the 4 A's were prioritized in training in a way to understand schizophrenia. So these 4 A's are loosening of associations that we were talking about before. The second one is affect and ambivalence. Those are a bit similar in the sense that there's the negative symptoms in the disease. And the last one is they call it autistic isolation, but I think one way to think of it is the cognitive changes as well as the social changes of the person. And again, going back to the emotional symptoms, a lot of people were trying to figure out, okay, what are we going to prioritize here? Are we going to prioritize the thoughts that are changed, the perceptions that are changed, that's the hallucinations, or are we going to prioritize the cognitive changes and the changes in the mood? So there's a lot of different things that these patients are presenting with, a lot of different flavors of the disease. And it was difficult for them to think about how do we, which one is the most important for diagnosis, which one's going to help us distinguish this diagnosis from other ones. So another note I had was, this is also around the time that, Freud was getting a lot of attention. So there was psychoanalytic theory, psychodynamic theory, and that study of the mind kind of ignored the brain to some degree, the neurology of it. So they thought of it as, they called it a psychotic reaction. And they said it was a fragmented ego due to a rejecting or ambivalent mother. And treatments included remothering the patient to build a stable ego. So that was how they thought about schizophrenia early 1900s. Next slide, please. These are some, quotes that I think show the negative way in which these patients were viewed. And, they said about institutions are confined in expressionless faces, indifferent to everything. The capacity for work and caring for themselves diminishes. A lot of these negative, ways of viewing the disease. And when you see patients who are well controlled on the disease nowadays, it's vastly different. So it's interesting to see how far we've come. Next slide, please. So for the diagnostic criteria, again, we had the first rank symptoms that we were talking about. So those prioritize sometimes the hallucinations, the thought disorder, and the second rank, which was more the mood symptoms. And there was a lot of talk about what they should prioritize for the diagnosis. And what they realized was, if we prioritize the hallucinations and the thought disorder part of it, the delusions, it'll be easy to identify and easy to reveal, because the cognitive changes, the mood changes, it could be a lot of other things. So how do we differentiate them? So they started to prioritize these other parts of schizophrenia to help them differentiate it from other diseases, such as bipolar disease or major depressive disorder, which can have psychotic symptoms in acute episodes, but they won't have it outside of those episodes. Next slide, please. We come finally to the first DSM. So DSM-1, 1952. So they even said themselves, this is synonymous with the formerly used term dementia praecox. And again, the use of term psychotic reaction. It's how this person's ego is reacting to the environment around them. And it's they describe it as a change in the reality relationships and concept formation. So even today, when we think of psychosis, so not just schizophrenia, but psychosis in general, we think about, is this person grounded within reality, or are they not grounded within reality? And it again touches on those different aspects of delusions, hallucinations, intellectual changes. Next slide, please. Here are some of the subtypes. So I'll go into the subtypes a little bit more in detail now that we talked about before. So the simple reaction was, a lot of it was the social relationships were dysfunctional. They weren't able to keep relationships. They weren't able to go have a job and maintain a job. The functioning was the primarily impaired thing. But they didn't really have the severity of delusions or hallucinations that the other patients had. Hebephrenic is a patient that is, we think of it as a regression. Okay, so these are adult patients, for example, that act very childlike. Think of like a 6-year-old, like throwing a tantrum. So they might be laughing inappropriately or giggling when they shouldn't be. They might have these kind of silly behaviors, and they might have some hallucinations and regressive behaviors. But the big thing to think about them is really, oh, this person's very childlike in their demeanor and how they interact with the world. And sometimes these behaviors almost seem like tantrums in an adult. Next slide, please. Catatonic. So this is a big one. And this is where they have motor symptoms. So a catatonic patient, there's two different types, categories of the catatonia too. There's the excited kind, excessive motor activity, where they're doing kind of more bizarre activity. They're not able to relax. And then there's the more common, which is the like stupor, mutism, negativism. So what we're thinking here is a patient that doesn't move at all, or sits quite still, is not eating, and doesn't really interact with the world around them, or interacts in a very fear-based interaction. So the vegetation is really the thing to think about in these kinds of patients. There's paranoia, kind of self-explanatory, and they have different things here: persecutions, grandeur. Ideas of reference means like they give too much thought about specific things going on around them. They, for example, like you might have a patient on a geriatric psych unit that's saying, oh, these nurses, like they're talking and I can't really hear what they're saying, but I know they're talking about me. I know that they're saying bad things about me, and that they think that I'm just faking it or something along those lines, that I'm not being a good listener, I'm not following the directions. That would be like a paranoid subtype. Next slide, please. And then there's all these undifferentiated ones. These were, again, because they were trying to think of it as a progressive disease, they wanted to try to include this in the subtypes. Next slide. And then schizoaffective disorder was actually a subtype of the disorder. We'll talk a little bit more about that in some of the future slides. And childhood type. So now we think about early onset schizophrenia. And I think that's nowadays, I think we classify as below 13 years of age. I think there's a very early onset schizophrenia too. That's I forget what the cutoff is for that. I don't know if it's 10 years or something. I can't quite remember. But there are. I went to the child psych conference last year, and they described a 2-year-old that they treated for psychosis with clozapine, and I think they had to cut the pill in like fourths or something like that, or eighths, I forget, and titrate up extremely slowly, because how do you prescribe a medication for a 2-year-old? But extremely rare, extremely rare. But they did include that even in DSM-1, 1952. Next slide. DSM-2, 1968. Not major changes. I highlighted some of the things that they tried to highlight themselves. One thing that they really focus in on here that I think we continue to do now is the thought disorder part. So they really were like, this is a change in how this person thinks. The loosening of associations, their thoughts are disorganized, they don't connect clearly like we would expect them to. But then they also have these other symptoms of ambivalence or loss of responsiveness, empathy, things you might see in depression, or like late stage dementia, late stage Parkinson's disease that these patients also seem to have, along with the cognitive changes. Next slide. Some more subtypes, not major changes here really. They expanded a little bit upon the childhood type, but I think what I wanted to highlight here was how vague this is. For a childhood type, they said general unevenness, gross immaturity, and inadequacy in development. I mean, that is such a broad way to diagnose somebody. I think that's why we ended up with patients who likely had ADHD or maybe autism or something, who ended up getting lobotomies. So this is, I think, a bit unfortunate, but we've come a long way in our diagnostic methods. We can move forward from here. Next slide. In 1972, I just want to touch that there was kind of an increased push to get actual criteria. So those are like descriptions, right? These are like actual criteria, like you need a certain number of the A criteria and the B criteria and the C criteria. That's what we do now with our diagnoses. And that's what we did with DSM-3 moving forward. So that was the big change in 72. Next slide, please. DSM-3. highlighted again the onset age before 45. But I think my favorite part about this is it should be noted that no single feature is invariably present or seen only in schizophrenia. I think that's a really great quote from the DSM-3. I think it is something I'm sure we have hopefully realized by now, that there's so many different features, so many different presentations, makes the diagnosis quite difficult sometimes. Next slide. The next few slides are just DSM like 3, 4. Yeah, we can kind of skim through these. I'm not sure if we share slides with at the end or not, but I added them in just so we have them. So 1980 was DSM-3. And we had they kind of differentiated some of the delusions. Next slide, please. I think, yeah, DSM-4, 494, and then our most recent I saw in terms of the DSMs between these years.
As we jump back in here, and sorry about that little blip, it's really interesting based on what I was talking about earlier in the talk, that in 1980, they talked about no single feature is invariably present. I'd forgotten that was in DSM-3, and that really, tells the tale. So jumping back into this, what's going on now? What's happened in the last 5, 10, 15 years? And are there subtypes of schizophrenia? And are any of the studies or subtypes that are being studied or examined useful? So, well, we had, I mentioned earlier that the human genome has been cloned, and that led to looking at DNA sequences. And there's actually consortia of researchers with more than 100,000 patients that have had their DNA sequenced. And there are also hundreds of thousands of persons that don't have a diagnosis of schizophrenia. And when you compare those DNA sequences, you can start to detect variations in the genes. And these are called GWAS studies, or genome-wide association studies. And this is a paper from about 2015. I think the press release on this came out in 2014. And this is from one of these consortia with lots and lots and lots of patients. And this study basically says that there are 8 classes of schizophrenia identified by characterizing phenotypic features in a genotypic-phenotypic relationship. And this is pretty complicated, and I'm not going to get into the minutia of it, but if you look at the panel on the right, they've got disorganized and moderate process and severe process. It's really a bit of a tortuous subdivision. This is going on 10 years in the literature, and really none of us are using this in the clinic. This has not made it into the clinic where we're testing people for their DNA patterns and then saying, oh, you've got subtype 7. So this is not, born critical fruit. This is an older study from a number of years ago, I believe the 1980s. And this is an imaging study with not a lot of patients. So this doesn't have hundreds of thousands of patients or thousands of patients. And I like this because this is in living patients. So this is positron emission tomography. And in positron emission tomography, you put a little tiny piece of radioactivity, not enough to cause any problems. You just put a little bit of, maybe radio-labeled carbon on a molecule of interest, and you look at the patterns. And in this case, they put a little bit of radioactive glucose into patients, and they came up with a couple of different patterns. They had a hypofrontal pattern and a hypoparietal pattern. And those are just different parts of the brain. And image on the right is what a PET scan looks like. But the reason I'm showing you this is measuring glucose is a window into metabolism. And what we know from a lot of work that's been done in schizophrenia, that there's a pretty significant metabolic component. For example, persons who develop schizophrenia, if you go back and look at their blood tests and maybe some work that they had done before they developed schizophrenia, typically have abnormal glucose tolerance tests. They have abnormal insulin resistance before they ever caught schizophrenia and started to have any symptoms. So the thinking in the field now is there's a significant metabolic component, and this very early attempt at identifying subtypes using imaging sort of leverage that approach. This is a paper that I really like. This was done by Carol Tominga. She's a colleague of ours at UT Southwestern. And this has kind of an intermediate number of patients, a lot of patients for the type of study it is. Looks like about 700 with schizophrenia or schizoaffective disorder or bipolar disorder. What makes this a neat study is they used a bunch of the sort of patient buckets, if you will, people who had a diagnosis of schizophrenia or bipolar disorder or schizoaffective disorder. So that heterogeneity that Dr. Singh was talking about and that I've been talking about, and how, we make the diagnosis because you have a set of symptoms that we can observe or that you're telling us about. Can we sort of sort those folks out by other things? And they used psychological measures. They used some physiological measures, auditory stimulation, saccadic control, things like that, to characterize diverse aspects of brain function. And they were able to identify 3 biotypes. And the biotypes have a broad distribution of persons that have different diagnoses. So in this case, the prior diagnosis was not that useful. You still could be divided into a biotype. And so this is a really interesting study that was well powered. Again, this hasn't led to changing anything we do in the clinic. We're not doing neuropsychological stop assessments. We're not looking at auditory stimulation paradigms when you come into my clinic to make a diagnosis. But it was a really good start at trying to do some of that. Of course, we're in the age of AI. This is a paper from about 4 years ago, using machine learning and artificial intelligence. And basically, they dumped a bunch of imaging data and some other things, education, demographics, things like that. And they came up with 2 distinct neuroanatomical subtypes using machine learning. Again, there wasn't a large number of there's a reasonably large number of subjects here because there's a lot of patients with schizophrenia that have been imaged. But for example, they didn't include other diagnostic categories to sort of distinguish them. They just worked within the schizophrenia field. There was some overlap in the middle. So you can see the little Venn diagram on the right. The thing on the left is just some of the imaging studies that have been done and the changes you see between their 2 subtypes. So, this appears to have, using artificial intelligence and using imaging modalities may be a way to identify subtypes of schizophrenia. This is a really nice paper from a few years ago, 2 or 3, 4 years ago, that kind of combines a lot of stuff. So can we combine genetics and psychological testing? But one of the nice features about this paper is it had trajectories. So it looked at trajectories over the age span. And it also focused on cognitive stuff. So we're pretty good at looking at psychosis and the positive symptoms, and we're actually pretty good at treating psychosis and the positive symptoms. It's not without limitations and side effects, of course, but we're not so good at treating the cognitive symptoms. And the cognitive symptoms are probably contributing the biggest component to disability, lower quality of life, lower employment, lower education. So this is a real, challenge for the field. Can we, figure out who's going to be cognitively stable, who's going to have impairment, and how that's going to happen? And they came up, as you can see on this figure right in the middle of the screen, they came up with 3 flavors. Folks that were cognitively stable, that may have had the diagnosis, of schizophrenia, folks that had pre-adolescent impairment or early impairment, and folks that sort of were cognitively stable till their teenage years and then had a rapid decline during adolescence down to a severe cognitive impairment level. What's really interesting is if you go back to Bleuler's original descriptive categorization of schizophrenia, these cognitive trajectories probably capture some of those descriptive types like hebephrenic and so on and so forth. There may be some real value into trying to match those descriptive types up with the trajectories of cognitive impairment. So just a little bit more from this study. When you start to break them into these 3 groups, pre-adolescent cognitive impairment, adolescent decline or cognitively stable, we can look at education level. We can look at general cognitive ability. We can look at the PANSS total score. PANSS is a measure of the positive and negative symptoms. And you can see the folks with the adolescent decline have the highest symptom scores. They tend to be the most severe. So that could actually be useful. If we know your cognitive trajectory, it could be predictive of how severe your illness is going to be. That might be a good thing to know. The other thing that's on here in panel D in the bottom right corner is the global assessment of functioning. This is just sort of an assessment of how well a person functions. And the lower the number, the worse the level of functioning. And we see in the adolescent decline group, they have the lowest global assessment of functioning. Just to give you a benchmark for this, when we assign a GAF, when we used to assign a GAF, a global assessment of functioning score, if somebody is an inpatient for any reason, we always made sure it was below 40. So the adolescent decline bucket is sort of heading towards severity at baseline that is pretty close to what our hospitalized patients look like. Whereas the pre-adolescents and the cognitively stable appear to have a better global assessment of functioning. So that's actually pretty useful prognostically as well, and could be useful if we had treatments for cognition that might need to be started earlier rather than later. Finally, they've got this really busy graph at the end, and I debated whether to show it or not, and I just figured you guys could handle it, and I'll try not to mess it up. The really easy part is the diagnostic category. So the control subjects are schizophrenia free, all right? And the cognitively stable, the adolescent decline, and the pre-adolescent impairment groups all have schizophrenia. And on the right side, you see what those sort of markers are. We have a polygenic risk score for schizophrenia, which is a measure of genetic stuff, a cognitive polygenic risk score, sort of an education score, and an ADHD score. And so polygenic risk score is a way to just quantify how much genetic risk you have for a certain diagnosis. And you can see that the adolescent decline patients have the highest blue bar there for schizophrenia polygenic risk score. So, that's really the genetics are really driving the adolescent decline flavored schizophrenia. So that's kind of what's been going on there. And so, we always want to know what's the answer, what's the take home message. Descriptive diagnoses pretty much have low utility. I mean, most of the time in psychiatry, we treat symptoms. If you have psychosis, we treat psychosis. If you have a mood disorder, we treat mood. If you have anxiety, we treat anxiety. We don't usually treat diagnoses. We don't have a cardiac enzyme, a troponin I. We don't have a prostate-specific antigen. We don't have a blood biomarker. If you come into the emergency room with schizophrenia, we don't draw your blood to see, this biomarker that's going to tell us the answer. I showed you studies from like 4 or 5 different directions: genetics, neurophysiology, artificial intelligence. They used imaging, a study that kind of combined them all. Nothing really converges. There's nothing really actionable. And other than that really small PET study that had like 8 or 15 subjects, none of those studies I showed you consider the metabolic perturbations that we think are part and parcel of developing schizophrenia, particularly cognitive impairment. And we're in the age of genetics and the age of genomes. And in the case of schizophrenia, genetics have helped, but it's not really actionable. When a patient comes into the clinic, we're not saying, "Oh, we got to draw your blood and get your genetic sequence so we can decide how to treat you." There's a few tests out there that say, "Oh, maybe you should use this drug or not use that drug." I spoke with a family the other day about that. They're mostly telling you about antidepressants, maybe here and there about antipsychotics. There's some blood tests that are important to figure out if you're a high metabolizer or a low metabolizer of a certain drug. But in general, personalized medicine has not really been deployed at the genetic level in mental health, and particularly schizophrenia, like it has in cancer biology. If you have a tumor in cancer biology, you go into the clinic, they stick a needle in it, they take a little bit of that tumor, they send it out for sequencing. There's big companies that do this now. They know the marker, all the genetic markers and panels of what mutations they're looking for. And then they have an algorithm. They have a treatment algorithm. If you have these genetic markers, this is what's indicated. If you have these genetic markers, that's what's indicated. We don't have that in psychiatry. We don't have that in neurology. We don't have that in mental health. So the genetics have been important from a research standpoint. We've developed this thing called a polygenic risk score, but it's not really widely deployed or actionable. So that's where the formal part of the rant is going to end. We thank you for listening, and we do have some time for questions. And yeah, we'll stop there.